plans will change this provision in order to meet the provider halfway, or in order to get the provider to participate in their network. There's a very small provider that had a significant number of recoupments. They didn't like it. Many of them were by offset. They got very frustrated, and when the contract renewal came up the next point, they asked me to negotiate with the plan to change this provision. And one of the big national plans actually agreed to make the period of time that both parties could go back a year. So that was quite a nice win because it protected now the provider from overpayment recoupments going beyond 1 year past, 1 year prior. I was going to mention one other thing just in regards to underpayments. In the RFP, the sample contract, there is very clear language in it that says that the MCO can recoup payments made to providers for services provided to enrollees during the periods for when HCA recoups any premiums. So if HCA makes a Medicaid eligibility redetermination and then notifies the plan that 3 months ago they decided the person was no longer eligible and they recoup from the plan the premium payments associated with that individual, then the plan can recoup overpayments to you, basically all the payments that you received from the plan when you thought that patient was eligible, when the plan thought that patient was eligible, but now they're not. So surprise, the plan is taking back the money from you because they had their premium taken back from the state. Now this has never seemed very fair to me because you can't exactly take the service back from the patient. The plan says, and the RFP says that you can of course bill the patient or bill the other provider that might now be responsible during that period when you thought they were eligible but they're not actually. The problem with that provision is that typically, usually the payment obligations fall to the patient and the patient won't pay, or it falls to another plan and you'll have missed the plan's window for timely claims filing, and so they'll deny payment, and so you'll lose on both grounds. So this can very much work against you if there are a lot of retroactive or retrospective eligibility determinations that change an individual's status retrospectively, and if the state doesn't tell the plans quickly and the plans don't tell you quickly, you can find yourself receiving a lot of recoupments of overpayments. Dispute resolution is going to be described in the contract. I think the most important thing here is that you have an easy, streamlined process for disputing and appealing claims decisions, and then something that may be more elaborate if there are systematic or large, significant disputes that you have with the plan. So, for example, if you have significant credentialing issues, complaints with the plan where they're not following their own policies and procedures and credentialing your practitioners quickly enough, or they're systematically not complying with the state's rules on medical necessity and you're being denied services, then you might consider some of these other additional steps where you can take action against them through something more significant. Informal negotiation is usually the point that I think makes sense to start, where each party in good faith tries to negotiate and resolve any issue. Where that's not successful, sometimes you might elevate it to mediation. Mediation is simply a process where you sort of have a Secretary of State go back and forth between both parties and try to reach an outcome that both parties are amenable to. And then third, you may have arbitration in your contract. If that's something that you like, to avoid litigation in court, you may have arbitration. My one piece of advice to you, if you are an organization or an agency that prefers arbitration to going to court, make sure it's binding arbitration. Binding arbitration is when the parties can go to court to enforce the arbitration decision. Why is that important? That's important because if you win through arbitration, you don't want the losing party, like the plan, to go to court because now you've paid for that dispute twice and you've sort of created an appeals process. So I say if you're going to go with arbitration, make sure it's binding on both parties. Now, one part that can get kind of tricky for providers where you can miss your opportunity to go to arbitration or go appeal certain types of systematic issues is that many plans, have their internal appeals process. And if you don't exhaust their internal appeals process, then it often cuts off your rights from pursuing the dispute through one of these other dispute resolution processes. Well, that can happen not because you're not doing your due diligence and going through that process, but you sometimes can get caught in the process. So if the plan has 2 or 3 appeal steps, and you've lost in step 1, if you lost in step 2, and then you go up to step 3, and then you don't get a decision by the plan. Well, you can't pursue these other processes because you now have not exhausted the plan's internal appeals process because the plan hasn't given you a final decision. So it kind of leaves you hanging. That's not a good place to be. So you want to make sure that when you review the provider manual and it describes the internal appeals process, that there are time frames for making decisions that the plans have to abide by. And of course, if they don't reach a decision within a certain number of days, then you should be the default winner, because you just do not want to end up in the situation where you're caught or prevented from taking further action because you're in this appeals process limbo. I always want to point out that if there's patient cost sharing involved, you are responsible for collecting it. And I know this isn't so much of an issue in Medicaid, but if there are any commercial lines of business that the plan has where the patient has a more significant amount of cost sharing, or a commercial plan like an exchange plan that has a high deductible amount, these can be significant. And you should recognize that you are going to be essentially looking to the patient to get paid, not the plan if you have a very high deductible, because the patient will have to exhaust that deductible first. In New York, I've been negotiating some contracts there over the past few days, and the plans are guaranteeing 105% of a very good rate to providers. Well, it sounds really good on paper because it's not just 100% of that very good rate, it's 105% of that very good rate for their exchange products. Well, why can they do that? Because they're not really paying those dollars. The patients have substantial deductibles, $5,000 to $7,000, $7,500, and even $10,000 deductibles. It takes a long time for a patient to exhaust those types of out-of-pocket costs, and so the plan is basically telling the patient that they have to pay 105% of this really good rate to the provider. The plan's not actually paying it. So it can look, if it looks too good to be true, it probably isn't true. And as in this situation for these providers in New York, for exchange products, the cost-sharing obligations is your financial risk. So you have to keep that in mind when you're looking over payment rates. If you don't know whether the plan has a high deductible and they offer an exchange line of business, then by all means go online and see what the deductible is that applies to that particular plan. Or ask the plan for that information if it doesn't seem to be online. This is something that won't be found in the contract itself. In most contracts, you can't actually reduce the patient's amount of cost sharing either. If you go back and you think about why plans even introduced having co-payments or deductibles, it was so that patients had more skin in the game, and it was basically a kind of blunt method of utilization control to make sure that it was really worth the patient to come into the office to receive the service. If you have a charity care policy or some other policy where you discount cost-sharing obligations to patients, you may have a contract that actually bars you from doing so, because many of these managed care contracts require you to collect cost sharing. They don't make it optional or discretionary. So if you do have a charity care policy and you want to continue applying that policy to patients, then what you need to do is negotiate some language here so that perhaps any patients that are subject to your charity care policy, you are allowed to waive or reduce their cost sharing obligation. If you try to ask for the ability to waive or reduce all cost sharing for all patients, plans will probably turn you down because then it will prevent that blunt utilization technique to do any work. But for the patients that have financial need, plans have been willing to allow you to waive or reduce cost-sharing amounts because they recognize that those amounts could bar the patient from getting care that they need. And if they don't get the care they need, then they could end up getting more costly care in hospital or other residential facilities. And then one last warning that if you are a provider that typically routinely waives or discounts payment obligations from patients, you should also avoid that because some plans have sued providers saying that when that's happened routinely, that they have been actually not submitting claims for their actual charges. They sue providers and they say it's not that your charges that we should be paying, it's your charges minus whatever this amount is that you routinely practice discounting or waiving. That's the actual charge, and you should be billing us the same. There's a group of safety net providers basically that got sued by Blue Cross under that argument that the Blue Cross was asserting that it was entitled to the charity care rate that these providers were charging patients, not the going rate that the providers were including on their claims to Blue Cross. My favorite, all products clauses. Many of your contracts will include clear language that requires you to participate in all the plan's lines of business, and not just their current lines of business, but also prospectively. The way these provisions are written, they're requiring you to participate in the plan's network for any line of business, and typically there's language that says that the plan can also add new lines of business and new reimbursement rates in the future, and you're also bound to participate. Well, that language essentially means that if a plan creates a new line of business, they can automatically add that to your contract without getting your approval. And that means that a plan, for example, could add a commercial line of business that pays half of what you get under your contract now, and they would be allowed to do that because you had already agreed in advance to participate in this other line of business as part of their network. So usually it's a good idea to modify this provision so that you have the opportunity to opt out in the future if you don't want to participate in any of these new products that are offered by the plan. And to me, that's only fair. It's not much of a contract if the other party can at any time change the fees that they're willing to pay you, and that's essentially what these contracts can do if there's an all products clause that includes future products. The other thing you might want to think about is that some products that are included in these contracts, some lines of business you'll see will have reimbursement rates that are woefully inadequate, that they're not sufficient to meet your cost structure, and you'll want the ability perhaps to say yes to some lines of business like Medicaid, but no to maybe another line of business like commercial or vice versa, so that you get paid a reasonable amount, and it's not all or nothing. The all products clauses essentially turn your contracts, though, into an all or nothing proposition where you have to commit to participating in all products or no products at all. That very much weakens your leverage in negotiating individually lines of business. A fairly recent provision that started to appear in managed care contracts is called what I call the regulatory penalty provision. Many state Medicaid agencies have started fining their Medicaid plans if they violate or they don't live up to their contracts with the state. In turn, many of the plans are turning around and fining or sharing some of those fines, if you will, with the providers, essentially downstreaming some of those fines so that the providers have to pay a portion of the fines that they paid to the state. Now, I don't think that was exactly the state's intention here. Many of these types of fines related to not meeting network adequacy provisions, and in that case, they wanted the plans to exercise greater oversight of the providers so that they knew if they didn't have an adequate provider network, or if they knew that a provider closed their network, or if they knew that provider had capacity issues and they didn't provide appointments within the appointment standards. So they wanted states, I think, wanted plans to step up and do more oversight and enforcement. Well, plans responded simply by including this provision in this contract so that if they are fined in the future and it relates to something that the provider should have done, let's say under their provider manual, that then they could pass down some of these fines to the provider. That means that you essentially have unlimited financial liability for noncompliance with a provider manual, and that does not seem like a good situation to be in. Let's say, for example, under the provider manual, you have to notify the plan when a practitioner's left, or when you you haven't met capacity and you can't accept any new patients, and you don't, because many times providers don't meet this obligation because they have 1,000 other things going on. Well, in that event that you didn't notify the plan of something and the plan was subsequently fined by the state, under this provision, the plan could downstream some of their fine to you, probably on some sort of per capita basis, and make you liable. To me, that's unfair. Sometimes you don't meet a provider manual requirement simply because you don't do something, but sometimes you try to do something and you make good faith efforts to comply, but it's not enough. In any case, if you get fined under the regulatory penalty provision, you're not going to be able to appeal it or dispute it with the state, because the state's contract is with the MCO. And by your contract with the plan, by agreeing to these regulatory penalties, you are promising the plan that you will pay your share, essentially, of these penalties. That's something to think about. I usually don't think that a provision that requires you to pay some sort of undefined amount, unrestrained amount, and a provision where you don't have any ability to appeal or dispute the fine is not a very good provision for a provider. So this may be a provision that you want to try to strike or limit in some way so it's not unlimited financial liability. In the case of one provider, they told a plan outright that they would not contract with the plan if this clause was included in their contract, because they did not think that it was financially, they did not think it would meet their fiduciary duties and be financially responsible. In that event, the plan actually took the provision out because it was more important to that plan to keep the provider in their network than to not. So again, it goes often back to how much leverage do you have with the plan, who needs who more, and if you do that analysis that we talked about in the last webinar of knowing how much leverage you have, then it can make these individual decisions on whether to push back on particular provisions a lot more informed. Because sometimes I get questions of, will plan, push back, or will plan accede to our request? And without having done that analysis of knowing how much the plan needs you in their network, it's really hard for me to say. I don't have a secret, ball where I can look through the ball into the future and know exactly what the plan's mind is on that. But if you've done some analysis for how much the plan needs you because you're the only one in their service area that provides an important service, well, then you know in advance that you could probably have a little bit more leverage than the average provider. All right. At this point, let's shift to some other contracts, what I call the standard terms of conditions, provisions that you'll see in these managed care contracts, but also probably see in some of the other contracts that you have just with other vendors, but I'll explain how they're important in the context of managed care. So first up is the parties to the contract. This might sound like a no-brainer, but you should make sure that the contract accurately captures your legal name and specifies who the MCO is. In some of the strange contracts, managed care contracts I've seen, it's been very hard to figure out who the other party is on the other side. In one state, the plan actually creates an IPA in the provider's contract with that IPA, and then that IPA has a contract with the plan. But the plan owns the IPA. And under this very bizarre managed care arrangement in this state, the IPA has no financial liability. Only the plan does. Well, the problem is that from the provider's perspective, they don't have a contract with the plan. They only have a contract with an IPA. So they really don't have much assurance that that party that they're contracting with has any payment responsibility at all. The other legal reason for why it should be important to specify who the parties are and include a provision that bars third parties from enforcing the contract is because many of your Medicaid managed care contracts do have service obligations, access standards, appointment standards, and whatnot. Well, if a patient sees that you did not comply with one of those standards, you don't want them suing you for not complying with one of the access standards that are in the contract. So typically you want a provision that bars a patient who is a third party from trying to enforce the terms of the contract. There were a number of significant cases in the beginning of managed care where patients were actually suing providers on the basis of violations in the plan's provider's contract with the plan. Next, breach and cure. If you do have a situation where there's been some kind of breach in the contract, you typically want the ability to fix the breach. So typically you'll see language that allows you to do so. But what I want you to really look at in the breach and cure provisions is typically there's a list of 5 or 6 reasons why the plan can immediately terminate the contract with you. Look at your rights to terminate the contract immediately. Do you have equal rights to terminate the contract because the other party goes into bankruptcy? Do you have the ability to terminate the contract if the other party loses their license? You want the same rights that they have to terminate the contract immediately in one of those dire situations. You don't want to be hanging on here where they're in bankruptcy and you can't terminate the contract immediately, meaning that you continue to provide services knowing that you're not going to get paid for those services because they're in bankruptcy. That's not a good situation to be in. So you typically want to amend or change the breaches clause to modify the provision that allows when you can immediately terminate the contract for their breach, and so that you don't get stuck. On term and termination, I encourage you to have a shorter contract period initially, because that gives you the opportunity to get out sooner if it's not a good contract, or to renegotiate the terms of the contract sooner after the initial contract term. There's nothing wrong with a so-called evergreen clause, which automatically extends the contract for additional 1-year terms, for example. That's fine, nothing wrong with it, but the term of the contract is important. One thing to take a look at, because this sometimes surprises providers, is that in some cases, if you want to terminate the contract, let's say you are halfway through the year of a 1-year term, and actually not, let me give you a better example. Let's say you're in month 12 of a 12-month term, and you've decided that you want to terminate the contract. Well, many contracts won't allow you to do it because you will have to have had provided 180 days in advance of the end of the term, and you're only a month away from the end of the term. And so you have to wait a whole another year in that situation before you can actually terminate and get out of the contract. It would be ideal if you can get the contract to say that if you want to terminate the contract, you only have to give 90 days notice. And it's not 90 days notice before the end of the term. It's simply 90 days notice, and then you can get out of the contract. This becomes more important when you have a problematic arrangement or situation with a plan, and typically you want to renegotiate certain provisions, and you're looking for the opportunity to threaten the plan with leaving the network by providing them notice, and by that notice, hopefully encourage the plan to sit down at the negotiation table and accommodate your requests or your concerns. The different types of termination that you might see are termination for cause and termination without cause. Sometimes this is a little bit confusing for people, and whether it's good or bad, it kind of a little bit depends on how easy you want it to be to get out of a contract. Let's say you have an individual practitioner where you have an employment contract, and there's a provision there that they can terminate the contract without cause. That means that before the end of the year, or whatever the contract term is, that employee can terminate the contract with no good reason at all and leave the contract. Well, the amount of notice that's required to terminate the contract without cause essentially it becomes your term, your contract term. Let me explain that, because your term, even if it was a year under the contract, is going to be altered by a termination without cause provision. So I'm not typically a big fan of termination without cause, because to me it changes the nature of a contract. Typically contracts give both parties assurances that each party is going to live up to their obligations for a defined period of time. When you have a termination without cause provision, it undermines that length of time and that financial certainty you have. So that can be good or bad, but you have to recognize it cuts both ways. It's going to apply to both parties, and if you have 90 days to terminate without cause, then they're going to have 90 days to terminate that contract with you also without cause. Typically, there's also language about breaching the contract, a material breach of the contract or material terms of the contract. Sometimes I get questions about what's material. Material is like one of those terms of art, just like reasonable is in the law, and it depends on the context. There's not black and white information about what's a material breach. Most say that something that's material is significant or serious and undermines the party's ability to perform under the contract. But it's a little bit vague about what exactly material means, and intentionally so. Renewal clauses under the contract, you'll see that typically the contracts will just automatically renew at the same rates, which is not necessarily a good thing. If the contract automatically renews on the same rate for 5 years, then it basically means you haven't had a rate change for 5 years either. So sometimes you might want to write language in your renewal clause that requires the plan and you to negotiate new payment terms 60 days prior to the renewal of the agreement. In regard to amendments, there's a couple of different things to think about. First, there's different kinds of amendments. All your contracts with MCOs will allow the MCO to immediately amend the contract as a result of any legal changes. It could be regulations, it could be statutory, it could be a change in the RFP that they're under by with the state. Automatically, they can change your contract because of those legal requirements, and there's really not much you can do about that. The next kind of amendment is an auto amendment. Plans routinely use the auto amendment provisions because it means that they don't have to get your signature in order to incorporate an amendment into the contract. So they send out a letter saying, we propose to amend the contract. We give you usually 30 days to object and opt out. But if we don't hear from you, then this automatically becomes part of your contract. Good, right? Well, sometimes good, sometimes not. It's great for the plan because it's very efficient, but it's not so great always for the provider. Sometimes it's not so great because these are amendments that are changing the reimbursement terms or adding a new line of business that does not pay well and that you don't want to participate in, or changes the terms and removes certain services. So it's very important to get these notices. Well, some providers have these letters that come in, these amendments come in, and they don't actually reach the person they need to reach at the organization or at the agency. The plans are typically required to send these notices to whoever is listed on the notice line in the contract. So I'm sure you've seen these managed care contracts. There's a notice provision you've probably glossed over. Typically it has 1 or 2 addresses where you have to send official notices to, and usually there's a blank that you have to fill in for where the plan's official notices should go to. This is why it's important to make sure that notice provision is accurate and going to be something that is sort of enduring and lasting. You don't want the notices, for example, to go to somebody who just files the notice in the filing cabinet and doesn't actually bring it to the right person's attention to make a decision whether to accept it or not. So make sure the notice provision has both the right person and the right level of person as well to reach. Now, nothing stops you from putting in a couple of names. Some providers have put in 2 different people that have to be receiving the official notices from the plan. That's fine too. Whatever you'd like, make sure it's covered in the notice provision. Some plans, I think, are unfairly doing auto amendments. They'll seek an auto amendment, give you 30 days to opt out or reject the amendment, but if you do, it automatically triggers their right to terminate the contract. To me, that gives the plan a lot more leverage to force you to take an amendment which you might not want to participate in because you realize that the consequences are that you can lose the entire contract. I would strongly encourage you to have that provision modified so that in the event the plan proposes an amendment by auto amendment, and they give you 30 days or 60 days to opt out, your opting out or your objection to the proposed amendment just means the amendment doesn't go into effect. It doesn't automatically terminate the contract, nor does it automatically give the plan the ability to immediately terminate the contract. And then lastly, the category of written amendments where both parties sign. Typically, this is because both parties are agreeing to a change by mutual consent. If you're negotiating this provision and you're not reaching good success, or you want to have some fun, you can also propose to the plan that you have the right to propose contract amendments. So just like they have the right to propose amendments, you have the right to propose contract amendments. Recently, I proposed to a plan that the provider should also have the right to auto-amend. So if they send an amendment to the plan and the plan doesn't object within 30 days, then the amendment should go into effect. I thought that would be nice and easy for providers to have. On the phone, the plan's counsel actually agreed to this, though I thought that was I couldn't quite believe it. And it wasn't really what we were seeking. We were seeking some changes in the immediate amendment in the provisions so that an objection to an auto amendment wouldn't result in termination. So we made another request so that there would be something that we could give away, and so that the plan could say no to. But they ended up saying yes on the phone to having the right to propose contract amendments. Later on, they came back and they said, no, we can't possibly deal with that because we have so many providers. We can't possibly agree to a term that amendments can happen automatically. And I only could chuckle, because many of you will have multiple contracts with many different HMOs, and it is a lot to juggle. But the plans, I think the lawyer kind of realized that later on, that you are in the same bind that they are by the potential of receiving a lot of amendments, being overwhelmed by it, and then having them go into effect if you don't object timely. Provider insurance requirements, I don't want to spend much time on this, but there's probably language in your contracts that require you to have insurance. Typically, you want to make sure that that accurately captures the insurance level you have, and then if you really want to be good, you'll want to make sure that the plan has to have insurance as well, because insurance helps you get paid. A plan that is solvent because they have a reinsurance policy retains their ability to pay your claims on time. So insurance is your friend in this regard. Indemnification is a provision that you've probably seen in many contracts, and sometimes maybe not being quite sure what it means. Indemnification is a clever legal device where one party agrees to be responsible for any of the claims made against the other party, irrespective of what a court might have said. So if in the classic situation of medical malpractice, patient is injured, patient sues their provider, and patient sues the plan. Well, the court says, or there's a legal judgment, jury verdict says that the plan was 20% responsible and that the provider is 80% responsible, and let's just say it's a $100,000 judgment. So the plan coughs up $20,000 and pays it over to the patient, and the provider coughs up $80,000 and pays it over to the patient. What happens next? Well, if the plan believed that you were ultimately at fault, essentially you caused the harm that the patient sued the plan for, then the next thing that you'll notice is the plan is suing you under the indemnification provision for that $20,000 that they paid out to the patient. Because an indemnification clause was where you said you would be responsible for payment if the plan had any costs or claims that were made against it. So they could essentially brush aside the jury verdict apportioning responsibility based on the indemnification language that's under this contract. So you could sort of imagine that these are used all the time to shift financial responsibility to parties that may be more appropriately responsible for the conduct. If you look at one of the big oil tank disasters where oil spews out everywhere, and one of the big oil companies is held responsible in a court, they probably have lots of contracts with vendors and subcontractors to help them do their work, and probably include indemnification clauses so that they can turn around and then basically sue their subs for the fines or the judgments that the oil company paid out as a result of the litigation that they incurred. So it allows them to pass along any kind of liability to the responsible parties. When you review the indemnification clauses in the MCO agreements, you want to make sure that they are equal and apply to both parties equally. Too many times I see indemnification provisions that are one way. You're indemnifying the plan, but the plan isn't indemnifying you. One of the nice things about many of these MCO contracts being written it's the same way is that they clearly allocate who's responsible for what. There's that section of the contract that says the MCO's responsibilities, and then there's this section of the contract that says the provider's responsibilities. This is very helpful in identifying who is responsible, particularly in situations of indemnification. The plan should be responsible for the things you see listed on the slide, like coverage decisions and utilization decisions. The provider is simply responsible for rendering appropriate care and submitting claims on time. So that each party has their responsibilities clearly laid out, so that if there is any kind of lawsuit and apportionment, you can always go back to the indemnification language. Now, one other quick thing is that the indemnification language usually extends to the other party's acts or omissions arising out of the performance of the contract, but sometimes it says language like not just except for intentional wrongdoing, so that you would be responsible if you were negligent on certain things, or the other party would be responsible if they were negligent or if they were did something intentionally, but not if they just made a good faith effort and something bad happened. And that's typically a good protection. That means that if you're indemnifying another party, that you're really only taking responsibility when you negligently do something wrong or willfully do something wrong. You're not always taking responsibility just when something went wrong. The other party has to show that a higher standard of essentially not living up to your responsibilities occurred. Access standards you'll see in your Medicaid contracts because the plans have to put information in them. And I wanted to point out that the RFP goes into some detail in regard to appointment standards, for example. So under the contract, HCA requires, for example, non-urgent symptomatic visits within 10 calendar days, and that includes behavioral health services from a behavioral health provider. It also requires urgent symptomatic visits be available within 24 hours from a behavioral health provider. So these are terms that are actually in your contracts with the MCO because the MCO must meet these appointment or access standards, so they're going to be in your contracts as well. If you look over these standards and you can't meet them, or you don't think you meet them all the time, then you may want to consider modifying the language in your MCO contract so that rather than requiring you to meet these standards, maybe you can whittle it down a bit so that you are required to make best efforts or all reasonable efforts to comply with these requirements. I would hate for you to sign a contract where you know at the outset that you can't actually live up to the terms of the contracts, particularly in something so important as access and appointment standards. You also don't want to be able to give the other side the ability to fine you in the event that there's that regulatory payment provision, penalty provision in your contract, if you were unsuccessful in removing it, or breaching your contract in the event that you can't live up to these access standards or appointment standards. There's going to be licensure requirements also in the contract itself. A couple of tips here. Usually you're required to report any loss of license to the MCO. I think that's fine, but I don't think it's so fine as if you're required to report whenever a clinician is under investigation. If they're under investigation by their state board, for example, I don't think that at that point you should be required to report to the MCO because the investigation hasn't been completed. There's been no final determination. There's been no suspension. There's been no termination. They're just investigating. Well, the last thing that usually can think about or deal with at that time when one of your practitioners is being investigated, the last thing you'll think about doing is notifying the MCO because you have more pressing concerns. So again, I think that it's important to take out the language if there's not been a final determination by some board, if there's not been any suspension or termination of an individual license. I also think that's good for protecting your patients. Some people say that it could be a liability risk for a provider to report something to an MCO if it hasn't been investigated and substantiated yet. Second, sometimes the licensure provisions are overly broad so that if a plan terminates one of your practitioners, they now have the right to terminate your entire contract. I don't think you typically want to give one of your practitioners that much power. You want loss of licensure by one clinician only to mean loss of that contract in regard to that one particular practitioner, not the entire contract itself. Credentialing, you'd be surprised maybe, or maybe not, on the number of questions I get in regard to credentialing, that plans are not credentialing quick enough, that they're sitting on credentialing applications, that as a result you have a new practitioner, for example, and you can't actually use them for seeing any of your of the plan's enrollees because they haven't been credentialed yet by the plan. Don't try to be too clever. Some providers have said, oh, well, we'll use that practitioner that's not been credentialed, but I'll put somebody else's name on the claim that goes into the plan. There's a word for that. Most times that word is fraud, and you want to avoid that. So if you put the wrong name on the claim form that goes in, that the person who did not actually render the service, that's a false statement. So not a good idea. Fortunately, there is actually some guarantees in the HCA contract. There's language in it that requires the MCO to notify a provider within 60 days of the credentialing committee's decision. At least that's something. I mean, in some contracts, you don't see any time frame for the plan actually responding or having a limit on how much time they have to review an application. There is language in the HCA contract as well for provisional credentialing. So if you have a new provider that's never been credentialed before by the plan, plans are allowed to offer one provisional credentialing for no more than 60 days, one time only for providers who are applying for credentialing for the very first time. So you might be able to avail yourself of that. Certainly whatever you get back from the plan, make sure it's in writing. So if you have a practitioner who has been provisionally credentialed, make sure you have that in writing. If you happen to have a plan that says, oh, it doesn't matter whether the practitioner is credentialed, you can put somebody else's name on that claim form, you get that in writing. See if that really will be something that's turned over to you in writing, because I find that hard to believe that they would agree to put that in writing, that they're going to disregard their own credentialing process. Some providers have dealt with this reality by delaying practitioners' start dates until they've been credentialed by one or more plans so that they know that the practitioner can hit the ground running. Some of you may have negotiated delegated credentialing agreements. This is where a plan can delegate to another provider its existing credentialing obligations. Many hospitals, for example, have delegated credentialing relationships for the physicians that they employ. They have to promise to follow the credentialing standards of the plan or national credentialing standards like NCQA, and then they take on the obligations and responsibilities of credentialing their practitioners. It sounds really good, except for the fact that you don't get paid anything for now doing some of the plan's work. It does put you in control of the timing, so some providers do like it, but you're not going to get compensated for the additional work that you're now doing. The plan usually does. A few words about medical necessity and utilization management. This is an issue that comes up in particular, I think, for behavioral health because so many services are subject to review and authorization and approval. Under these managed care contracts, the plan gets to decide whether services are medically necessary. They do have to follow many of the protocols and requirements that Washington State already has in existence, but they can use their judgment. There are some, there's an appeal process, of course. There's the ability to appeal the decision, but at the initial stages within the MCO, the plan decides whether the service is going to be authorized or not. One thing that you may want to recognize is that any behavioral health denial that's based on medical necessity will have to have a credentialed person making the decision. So plans have to have a board-certified or board-eligible physician in general psychiatry or child psychiatry, a board-certified or eligible physician in addiction medicine or a subspecialty in addiction psychiatry, or a licensed doctoral level psychologist in making denials related to behavioral health based on medical necessity. In addition, any actions have to be peer-to-peer, which means that the credential of the licensed clinician who makes the credentialing decision To authorize less than what's been requested by the provider must be equal to that of the recommending clinician. So that you have, if you're putting up a physician, they're putting up a physician. If you're putting up one that has a board certification or board eligible in addictions, that they're using that equal practitioner type of practitioner to make the decision as well. That's language from the RFP in Washington State. As I mentioned earlier, a lot of utilization management requirements apply in behavioral health for the specific services of behavioral health, but also for certain drug screening tests, as well as whether you can refer patients for rehabilitative services. How do you know what the program is from this MCO? Again, it's not going to be in the contract. It's going to be in their policies and procedures or in their provider manual, and it would be a good idea to take a look at those manuals, share them with your clinical team so that they understand in advance what the process is for appealing, what's subject to authorization and review and approval, so that there are no surprises. Under the RFP was very specific that plans had to use the utilization management protocols and level of care guidelines that are specific to Washington State. They have to be consistent with the HCA medical necessity criteria, and they also have to comply with all parity requirements. So there are some protections built into the contract for behavioral health providers. If a plan were to want to change any of their utilization management guidelines or protocols in behavioral health, they have to submit those changes to HCA for prior review and approval. All the plans are required to have behavioral health medical directors in management, as well as to have a behavioral health clinical director. So there's supposed to be people who have the right credentials involved in overseeing this process and decision-making. And then there's also supposed to be folks in the MCO, the community liaisons who are required to work with county behavioral health leadership, as well as accountable communities on health within the specific service areas. You should review the plan's provider manual as well as probably the RFP for the specific provisions that relate to the appeal process, how many days a plan has. Is it 10 days? Is it 5 days? If I recall, there's plans I think have 5 days. If it's a new request that's going in, 5 calendar days to request to approve or deny. I believe plans have 10 days are required to provide 10 days prior written notice if they want to modify something that's been previously approved. So 10 calendar days to modify something that's been previously approved. But all those time frames are spelled out in the HCA RFP. Lastly, to go full circle, as you can see, whether you win the provisions that were covered in this session is going to harken back to your preparation phase and understanding whether you have negotiating leverage or strength or not, and knowing how much the plan needs you. That will inform you whether you can push back on particular provisions. So I encourage you to think about that. Think about being a provider that provides great value to the plan, because there should be reasons why they want to contract with high-value, high-performing providers. At the end of the day, they will save money for the plans. I encourage you to work together as a team within your organizations to understand what the contract provisions mean. You shouldn't saddle one person necessarily to have the pleasure of reviewing a 80-page managed care contract, split up the work. Come up with your own checklists for how you review a contract. Some of these slides actually include some checklists at the end, but you can come up with your own slides, your own checklists as well, so that you're applying the same criteria or questions to every MCO contract that comes before you. Don't forget to do that prioritization phase where you're actually thinking about which are your highest priority issues. I was sending an email to a plan today before I got on this webinar, and I told the plan contract rep that I had 3 issues that I wanted to discuss with her. I said these are probably not make it or break it issues. I think we can resolve them. The provider is eager to sign a contract. And hopefully that she'll get on the phone and talk to me because I said there's only 3 issues, as opposed to sending back an entirely redlined contract to the plan rep. Not a very desirable situation for them to be in, because that looks like a lot of headache, and you don't want them to think it's a headache to contract with you. Lastly, when you're negotiating, do think about your services. Think about offering different services or offering different ways to get paid that support the work you do. Part of having managed care in the game is supposed to give these plans flexibility. They're going to be a little bit loath probably to be flexible in the beginning as they get up and running for any of the new plans or during the process of integration. But I imagine shortly after that, when they move to from the phase of lining up their provider network to managing their costs of care, that they will be more open-minded at that point to ways to manage their total costs of care and to providers that say that they can do that sort of thing. All right, if you're still with me after the last hour, I'm happy to take some questions.
Okay, Adam, we've got everyone on mute at the moment, so let me see if I can just unmute everyone and we'll hopefully be able to. So, as I unmute you, please be sure that you are self-muting so that we don't wind up with too terribly much background noise. Thank you, Adam. This is great. Okay, I think I've got everyone unmuted who I can unmute. So have at it with any questions, comments, feedback, other thoughts that you guys have for Adam here while we've got him.
Can you see the questions that were written?
Oh, there's a good question. That would require opening the question panel. Pop this out. Yes, there we go. Okay, so are there antitrust issues if several providers came together to have an attorney represent our similar interests in making contract modifications? Did you catch that, Adam? Oh, no, I muted Adam. There we go. Sorry.
Okay. Yes, there are antitrust issues, regardless of whether you have an association, a consultant, some other third party, whoever, negotiate a contract with a particular payer on behalf of all those providers. That still creates the same antitrust problems of potential price fixing together. Doesn't matter that you have a third party doing that work on your behalf. There's been a number of cases where associations, both trade associations as well as provider organizations, have engaged in this activity, and the courts have been not very favorable to them when they do that. What you can think of doing, and this is true of whether you have a consultant do this or an association do this on your behalf, is you could have an individual review the contracts and provide those contract feedback, I suppose, back to the individual providers, so long as the providers weren't discussing the terms, those terms together. They'd have to work separately and independently, but I suppose they could have one party do the review on behalf of all of them. I think in that situation they would also have to make sure that they either don't have the attorney or the consultant negotiate on their behalf together, or I guess maybe one of them could do it but not the other. There'd be a little bit of trickiness in that regard, but there could be no way that one agent, whether they're an attorney or non-attorney, negotiates collectively on behalf of those providers with the plan.
Adam, this is Kirby. Can I ask a question?
Sure.
It's related to that. So I know that medical providers go into what they call consortiums, and they go, and my understanding is they need to go into the consortium for medical service purposes. They can't go into it for the purpose of negotiating. They go into it because they need specialty care usually. But they do negotiate, but then they have, there's usually like a larger entity that is the head of the consortium, and that head of the consortium does the contract negotiation. So that's not the same thing?
Are these consortiums just something that the doctors have set up or they do themselves, or is this some sort of state structure?
I think it's the doctors do it themselves, but it's linked to large health, I don't really want to say their names, but it's linked to like large, an example would be Legacy, Providence, linked Peace Health, it's linked to them.
Right. Well, Peace Health have been subject to the antitrust litigation and had some big cases related to them, so I'm pretty sure that they're familiar with the antitrust laws. Typically, the bigger provider entities, if they have physician or physician groups that are part of them or connected to them, they actually typically negotiate capitated agreements with payers on behalf of all the physicians, and they take full risk or all professional risk, and so they are able to negotiate collectively on behalf of all the physicians that are part of their system or their network, and that's completely lawful. And then they turn around, and the network or the system will pay these individual physicians that are part of it. But they're not actually negotiating fee-for-service rates. They're negotiating risk contracts. So it's a little bit different than probably the contracting that you're doing, where you're not negotiating risk-based contracts individually. You're negotiating really fee-for-service contracts. And those you can't collectively negotiate through a consortium or an association or an individual or otherwise. I do hear from time to time that there are groups of usually private physician practices that are negotiating together. If they are, it's probably unlawful unless they have risk-based contracts. They may not be aware of the antitrust laws or may be ignoring it, but I imagine that if they were to get too greedy and ask for too much and the plans didn't like it and the plans were aware of what they were doing, then the plans definitely would have the ability to push back and to stop them from doing it or reporting them to the DOJ or FTC to get a government investigation started. So it's not really a great place to be in.
Thanks for the clarification.
Okay.
Okay. And then we've got another one here in the panel, Adam from Jared, saying some of our commercial insurance contracts with us as a facility versus credential each individual practitioner. Is this an option with the MCOs? Is there benefit one way or the other?
I have found that it's preferable to contract as a facility than individual practitioners. I do want to separate out credentialing versus contracting. Credentialing is going to be specific to individual practitioners. However, in some cases, if you contract as a facility, the credentialing requirements sometimes in some states are less. I've seen in some states where if you are contracting as a facility, then that facility simply has to turn over a list of its practitioners or clinicians to the MCO, and that's about the extent of the credentialing process. I think they're relying essentially on the licensure of the facility to do some of the checks that they normally would. So that varies a bit state by state. But if you're asking whether it's better to contract as a facility versus where I see sometimes the individual practitioners that work for you get managed care contracts, I would again say it's better to do it as a facility. And the reason is because you're billing as a facility under usually one tax ID number. That's the contracting party. Typically your clinicians are not doing their own billing. They're not independent. They are your employees or they're your contractors doing work for you. So they should not have their own independent contracts with the MCOs. They're beholden to you, and you should have a facility agreement. Sometimes the MCOs, by accident, actually send contracts to your physicians. They don't know that the physicians are employed by you, or they think you're like a physician group practice or something along those lines. You may just not have gotten the right contract from the MCO. The facility contract is the one that you want, not an individual contract for a practitioner by practitioner.
Great. So Jared, is that helpful? I don't know if you can speak or not, but if you guys all should be unmuted, so if you've got questions you want to ask out loud, feel free to do that. Otherwise, go ahead and just use the question pane. There we go. Yes, thank you. Great. Glad to hear it, Jared. Thanks. Kirby, since we have signed a variety of agreements with MCOs in an effort to enable them to submit an RFP, what is the best way to go back when we know who actually has a state contract and shore up these agreements?
Well, it's interesting that, and I think Kirby and I talked about this offline, about whether those MOUs were a permissible way to support their application. There's language in the RFP that defines what has to be in a provider contract, and one of the requirements for any of the provider agreements under the RFP language essentially is that you have to have rates in the contract. And MOUs often did not include the rates. It was merely parties were saying they would both make typically a good faith effort to negotiate rates after the contract was awarded. So there's not much of an agreement from the MOU. It's really like a letter of intent, but it's not. In most cases, it's not even contractually binding because there's not money that changes hands. It's sort of a good faith agreement that the parties will work together. So really, after you sign an MOU, if they get the award, you really have to go back to ground zero and negotiate the participation agreement as if it's a brand new thing. Now, if you've had some agreements in the MOUs where they've made some obligations to you, or there's some other language there that helps you, certainly draw on the MOU if there's some protective language there. But you'll basically have to start from zero in your provider agreements, and reviewing them and negotiating them.
Great. Okay, and we're just about out of time here, but want to see if we've got any final questions we want to get in from folks. Anybody else? Any parting words of wisdom, inspiration, or advice, Adam?
A practice makes perfect. I think that you would find that when you start looking at these contracts, many of them do have the same language, and so even though it's hard to look through it the first time, you will get much quicker on finding the right provisions to zero in on and prioritizing the issues you want to address. The slides here do include some questions that you can use in your internal process for reviewing the contracts, for looking for certain types of terms and figuring out whether they're in the contract or not, and then figuring out if you want to seek to change that. So I encourage you to do that, and then think broadly about what can make you a high-value, high-performing provider that plans want to contract with, because it helps them manage the total cost of care.
I just want to thank Adam for these presentations. It's a lot of information to assimilate, but it's really great information.
Thank you.
Anyone else?
Thank you.
Okay. Yeah, great. I think we'll sign off here. Again, I'll get a PDF of the slides out to everyone, and then the video recording a little bit later this afternoon, and then onward and upward. So thanks, everyone, for joining us. Thank you, Adam, again so much for your time for these two excellent sessions, and we'll see you all later. Take care.